Diabetes management is essential for our residents' quality of care. In Track 1, our resident Mrs. Olson received the appropriate care she needed thanks to her care team's effective communication. However, prior to her team's intervention, Mrs. Olson had poor diabetes management because she had been left on sliding scale insulin for longer than is clinically recommended. In the following scenario, watch as a medical director and pharmacist discuss the importance of good basal bolus insulin regime versus using sliding scale for better diabetes management.
Well, Melanie, that was a productive QA meeting. I was a little surprised to see the amount of sliding scale insulin being used in our patients. Looking over the data, I noticed Mr. Ashton in particular. It appears he's been difficult to manage in the past, and his attending continued the sliding scale insulin after his recent hospitalization, rather than placing him back on his baseline insulin regimen. I wasn't aware several other patients were sliding scale as well.
I was equally surprised, Dr. Phillips. I hadn't considered looking at sliding scale insulin prior to the updated Beers criteria adding it as a potentially inappropriate medication. Now that we've begun tracking the use of sliding scale at several facilities, it's definitely a prevalent medication. A recent conference I attended mentioned that the wide fluctuations in blood glucose with sliding scale are actually worse than keeping blood glucose as mildly elevated. The wide fluctuations in glucose tend to place more demands on staff and do result in more calls to prescribers.
I definitely prefer to avoid the fluctuations, especially hypoglycemia. Sliding scale insulin has been around since before I was in med school, and although there isn't any evidence it works, we've continued to use it. What approaches are other facilities using to minimize their sliding scale use? What regimens are successful?
The best approach is to mimic the body's natural insulin secretion, also known as physiologic insulin therapy or basal bolus insulin therapy. Basal given once or twice a day and rapid-acting insulin with each meal. It may take a few weeks for us to get it right, but I believe we can successfully implement a similar strategy here.
That's the strategy we've begun using at the hospital with our diabetic patients, and I've seen much better blood glucose control and less of a roller coaster. I'm pretty sure this is what's recommended in the AMDA guideline as well. If we can change the culture and focus more on providing the appropriate dose of insulin for each meal, I think we can develop better insulin regimens that may eventually require less testing.
I agree. If we have at least 3 days of fasting and pre-meal blood glucose readings, we can begin to recommend scheduled insulin regimens and make insulin administration much easier. It will be important for patients not to miss an insulin dose, even if their blood glucose level is normal. It's time for us to move away from the idea that insulin injections are to be used to lower blood sugars and understand that basal insulin is used to maintain blood sugar levels during fasting state and mealtime insulin is for the meal.
Yes, that's correct.
I think most staff is fearful of hypoglycemia. Unfortunately, holding insulin doesn't cover what the patient eats after the reading. Based on insulin's kinetics, we will definitely have more control if we focus on future blood glucose needs rather than chasing high blood sugars.
You're right. As a culture, we've been reacting to the blood glucose level that reflects the previous insulin dose, but don't do anything to cover the meal the patient actually consumes. We've seen less hypoglycemia in the hospital since removing sliding scale insulin protocols.
Yes.
We should add a correction dose into our plans so that if Mr. Ashton eats an extra serving of ice cream, his sugars don't go through the roof. We know that most of the residents are on liberalized diets and they're going to eat whatever they want, so we need to plan for that.
Great plan. After at least 3 days, we can determine how much insulin a patient needs each day, and then give them half that amount in basal insulin each day. The other half can be divided into 3 doses to cover each meal based on their daily requirements. For instance, Mr. Ashton consistently receives at least 40 units of insulin daily with the sliding scale in place. We could start him on basal insulin 20 units per day. And since we see by his meal intake sheets here, he eats more at breakfast and less at dinner, we could give him the other 20 units as rapid-acting insulin.
Good idea. So what specifically would you suggest?
I would suggest 8 units before breakfast, 6 at lunch, and 6 at dinner. Then we can also calculate his specific insulin sensitivity, so that way if he does have extra sweets occasionally, we can give him a correction dose if he experiences a high reading.
That sounds like a good start for Mr. Ashton. I'll contact his attending and see if I can get her on board with this plan. I don't foresee any problem with this. Then I'll follow up next week and see if Mr. Ashton requires any adjustments.
Great.
I think individualizing the insulin therapy rather than using the same scale for each resident will give us more success in diabetes management. It may take a few weeks to get the staff comfortable with the new insulin regimen, but it will allow the staff more flexibility in meal dosing and provide more stable blood sugars. Let's get an official protocol in place before the next QA meeting.
Okay. I'll get a protocol together based on our conversation, and I'll get it over to your office for your sign-off by next week. How does that sound?
Sounds very good. I'll speak to the Director of Nursing and work on a performance improvement plan. We might even make this our Quality Assurance Performance Improvement, also known as QAPI project.
Sounds like a plan.
In this scenario, our medical director, Dr. Phillips, and consultant pharmacist Melanie took steps to minimize the use of long-term sliding scale insulin. They noticed that sliding scale insulin regimens were not being used for just acute management of blood glucose in order to calculate a standing basal bolus regimen. They worked collaboratively to discuss the issue and put in a process for performance improvement. Now that we've taken a closer look at how and when to implement better diabetes management, let's explore more on diabetes and why the disease is of such concern in long-term care facilities in Track 3. You're on your way to becoming a know-it-all. Thank you.